Now, the care management elements within the organization that seem to have the um, strengths and contribute to this process, um, I think, is the fact that they've clearly identified the population, which involves those with high risk comorbidities, chronic care patients with complex medications, and patients with substance use disorder or mental health needs. Program development is definitely in its final phases in terms of an integrated substance use disorder treatment program. It is in that final stage of improving the discharge planning process and that transition of care to the community. And there seems to be a comprehensive plan in place in terms of power forms and a process and flow map that creates structure for the discharging nurse in terms of identifying what are the uh, uh, items and needs that he or she need to advocate for prior to releasing the patient. So those include having a primary care model, having an ICDT care coordination nurse linking our patients to community providers. As I said before, screening and treatment, 18 to 24 months from release. Social worker screening for MAT and CBI, contract providers for CBI, custody, enrolling our patients into CBI and monitoring them so that it takes the strain away from healthcare. And it's a dual effort rather than only a one-sided silo program. And then we have our TCMP contracted partners identifying and establishing IDs, Medi-Cal healthcare coverage, SSI benefits for our patients before they release. However, the only problem with that is that our patients have to continue to advocate for themselves in the community, get to a social services or security type office, and activate their Medi-Cal benefits in order for it to be completely active. And the final phase of the strength is the fact that our parole agents are now involved with making sure that they are communicating with a discharge planning nurse and providing demographic information to appropriately link them to something realistic that they can get to in the real world and in the community. The weaknesses of the program identified here are the advocacy may not be as robust because of the 150 patients that one discharge nurse or care coordination nurse is having to follow. I think it does require a workload assessment in more detail and to possibly identify the need to have a second care coordination nurse who establishes more time to communicate with the community, with our parole agents, and with any internal needs from our providers as far as prescriptions, medications, and communicating with our TCMP program to confirm that they do have medical and SSI benefits processed. Maybe not established because the patient has to go to the community, establish them, but at least processed. So I think the advocacy may be hurting because of the workload. And also on the custody side, there seems to be a lack of advocacy from parole agents because they may not truly understand substance use disorder as a chronic disease. More than likely, they see substance use disorder as a choice, and it presents a very negative stigma, which decreases any type of advocacy from the custody parole agent side. Follow-ups have a very difficult time in terms of establishing the appointment before our patients release to the community. And the main reason for that is the response time and the time given to the discharge nurse to try and link our patients to those providers. If a nurse is calling and they're not answering the phone, or they take a week to respond, you can imagine if the parole dates change and they go from 30 days to 2 weeks, there's a minimal amount of time for the discharge nurse to truly advocate and establish that appointment. So again, if you look down at the list of weaknesses, we have the negative stigma, the discharge nurse workload, the parole dates may change without notice, placing strain on securing community providers. Parole agents may not have all demographic information at 30 days prior to parole. That's a big one, because if we don't have the demographic information, how can we advocate for the appropriate providers that are nearby and close to that patient, or at least reasonably close to the patient? So parole agents, because of the number of patients paroling, they seem to be sometimes delayed in obtaining the demographic data, and sometimes they may even have the data at the 3rd and 10th day prior from release, which does not align with timely um, um, care coordination and discharge planning, which should be done at 30 days. Additionally, TCMP network is not, the third-party network is not always 100% in establishing the processed Medi-Cal documents and SSI benefits prior to release. So sometimes our patients do need to go out to the community and establish them for themselves, which requires more paperwork, and it decreases the patient's motivation to get those things done. So the more obstacles and the more challenges for these patients who are coming from a very dependent environment into a very independent environment, the more risk of recidivism, the more risk of overdosing, the more risk of cravings, and just a complete relapse, and the possibility of getting back out into the community and committing a crime and ending back up in prison.